Which is the prevalence of antibiotic resistance in the community-acquired infections?
The traditional concept that the problem of resistance is a problem mainly represented in a hospital-acquired infection needs to be revised, because now in several European countries like Italy we are observing a significant increase of community of multi-drug resistance bacteria also in community-acquired infection. Especially the most, for example, in a recent experience at the emergency department of a large hospital in Milan, studying a population of 500 patients discharged with a diagnosis of sepsis, 17% had an infection due to a multi-drug resistant bacteria, mainly P.Viale Enterobacteriaceae and methicillin resistant staph aureus. So in countries with a high level of circulation in the hospital, we should pay attention, we should take in a proper account also the risk of community-acquired infection due to multi-drug resistant microorganisms.
Which are the most important risk factors?
There is a fair amount of studies in the literature aimed to define the risk factors. And we must improve the number of experience to define the specific risk factors related to specific resistance pattern. For example, we have just a large burden of literature about the risk factors for P.Viale Enterobacteriaceae, where a history of hospitalization and exposure to antibiotics, residence in long-term facilities, and previous gastroenteric or genitourinary invasive procedures represent the most important risk factors.
How can we improve the management of infection in emergency department?
Starting from the idea that appropriateness is at least as important as timing. Some years ago, we planned a study in the emergency department of our hospital in Bologna, aimed to evaluate if the intervention of a skilled, dedicated, rapid response infectious disease team could improve the outcome. We planned a pre-post study. During the pre-phase, patients were managed by emergency department physician, while during the post-phase, every patient with a diagnosis of sepsis was managed by the dedicated infectious disease team. The result was a significant improvement in the outcome. The mortality in the post-phase was significantly lower, and being managed by the dedicated team was a variable independently associated to survival.
And what about the future?
The project we are planning is a project in which the physician prescribe the antibiotic alone, but supported by an application on the iPhone. The application works like a virtual infectivologist. The application is very simple, it's very easy to use, and it is based on a very easy decisional tree, because it was not planned to help us, the skilled infectivologist, but it was planned to help to improve the basic approach of every physician.